Okay, welcome back. Let's get started. This will be a video lecture for chapter number 20, Respiratory Disorders. Hope everybody is doing well out there. And we're going to get into some respiratory disorders. We're going to talk a little bit about respiratory anatomy. It's going to be great. So we're talking about respiratory distress. What we're going to talk about in this chapter is that respiratory distress, it can rapidly deteriorate into respiratory failure and arrest. As you can imagine, death follows quickly unless measures are taken to restore that ventilation and oxygenation. It can interfere with the delivery of oxygen to the tissue and exacerbate by stress response and an increased use of respiratory muscles. In this chapter, we will talk about cellular metabolism. With inadequate oxygen, it leads to inefficient energy production, and along with the respiratory acidosis. The combination of incorrect underlying problems, exhaustion, acidosis can overwhelm the body's attempts to compensate and actually restore homeostasis. We're going to talk about quickly recognizing difficulty in breathing and how to intervene, how important it is to ensure that the airway's open, that adequate ventilation, along with adequate ventilation and circulation. Understanding the anatomy, along with the physiology and the pathophysiology of the respiratory system, actually helps to provide the best care. All right, so let's talk a little bit about the anatomy and physiology. Let's review it. We talked about cellular energy, cellular metabolism, how the production depends on oxygen reaching the cell. Adequate oxygen in the atmosphere is number one. So you got to have that 21% oxygen. And so you got to think about those kind of things when you're dealing with maybe somebody who's underground. Anytime you go like deep underground, the possibility of not having oxygen at 21% is a real thing, right? We have to have an airway that's open, that it's going to allow air to come into the trachea, go through the bronchioles, get down to the alveoli. We need to think about the alveolus and how close in contact it is with the capillaries. That's what allows for that oxygen exchange to happen. We have to think about adequate hemoglobin, because if that red blood cell doesn't have hemoglobin, then it won't have the property to carry oxygen. We have to look at the cardiovascular system, because if we can't pump blood to the lungs, to the capillaries, to be able to have that oxygen exchange, then it's not going to work, is it? And anything that interferes, that can lead to hypoxia, cell dysfunction, and death. Cells must produce energy to carry out their function. Remember when we talked about cells and functions, we talked about not every cell is a cardiac cell. Not every cell is a liver cell. Not every cell is a brain cell, right? They have their own special functions that they must carry out. But all of them need oxygen to be able to carry out that function. We have two different types of metabolism, aerobic and anaerobic. Aerobic meaning with oxygen, and anaerobic meaning without. Remember what we get with aerobic, right? We're going to get heat, we're going to get water, and we're going to get a lot of ATP. And with anaerobic, we're not going to get that. We're not going to get a lot of heat. We're not going to get the water that we need. And we're going to get very little energy. We know also that we will get a byproduct of acid, right? And that acid is called lactic acid. And anytime somebody becomes more acidotic, that pH scale decreases, right? And so a lower pH level means more acid, and a higher pH level means more base. So the relationship between the pulmonary and systemic circulation, right? And so we talk a lot about it, but it's important. Here we have blood coming in from the inferior vena cava, up here the superior vena cava, coming into that right atrium, right? And we all know how it works. It goes through the tricuspid valve, into the right ventricle, through the pulmonic valve, and then where? Through the pulmonary artery. And that's going to let us come out here, right down here to the capillaries, where that oxygen exchange can take place, right? Where diffusion can take place. We get rid of the dirty waste and we receive oxygen. And that oxygenated blood comes back through the pulmonary vein, and it comes back over here to the left atrium. It's going to go through the bicuspid valve, into the left ventricle, through the aortic valve, and then up and out the aorta. And we know this is oxygenated blood, and it will go through the systemic circulation, feeding down here, feeding all of the cells, right? And then the process repeats itself. We're going to give these cells O2, and we're going to pick up the CO2, which is the waste. But it's something to understand that, you're going to die one or two ways, right? Either you can't breathe, right? And so you can't get oxygen to stack up in the alveoli, or you're bleeding out, right? But either way equals hypoxia, right? That's what you're going to die from. If the blood can't be circulated, then that's hypoxia. If you're running out of blood, it's hypoxia. All right, the anatomy, physiology of the structure and function of the lungs. And so we kind of go through this mouth and nose, right? And so we know that when we breathe in through our nose, it's a filter. You have that little cellula type hair that's a filter. It moisturizes the air. It comes to the pharynx, which is the throat. You have your nasal pharynx, your oral pharynx. It's going to go through the larynx, into the trachea, where it's going to come up to the carina. It's going to branch off from there to right and left main stem bronchi. And then from there to the bronchioles, and then to the alveoli. When we look at the bronchioles, we know they have smooth muscle that allow the diameter to change in response to what? To alveolar ventilation. So those bronchioles with that smooth muscle, if there's a reason to become constricted, they can. If they need to be dilated, they can because of smooth muscle. Beta 2 is what acts on smooth muscle to help dilate it. And remember, beta 1, 1 heart, beta 2, 2 lungs. The respiratory tract, right? So the lining of the bronchioles, they have that mucus lining that helps with air. When you take a breath in, remember a certain amount of that is dead air. We want to get that, hopefully at least that 300 milliliters down to the alveoli. But we're going to use any way we can to get it there. And so it slides down there better with that mucus. There's that microscopic hair-like cellular projections called cilia that I talked about a second ago that help to clean the air. So the walls, or the distal terminal bronchioles, right? That's where alveoli are located. They are single cell layer thick. And the reason why that is because during diffusion, we don't want to go through a bunch of stuff for diffusion to happen. We don't want to go through a brick wall. We much rather go through a piece of paper, right? So it's going to be much thinner there to allow for diffusion to happen. When we look at the alveoli and the capillaries, there's that respiratory membrane. It's separated by that extracellular fluid. And then diffusion of gases, it's going to depend on the concentrations on each side of that cell membrane. We have stimulates the increase in carbon dioxide in the blood and cerebrospinal fluid, or decreases the level of oxygen. What we're talking about there is that body's way of chemoreceptors being able to read that level of acidity, and if we have too much CO2, what are we going to do? We're going to breathe faster. And in the worst case scenario, if we start building up lactic acid, become acidotic, then the body's going to know that too. And the best way for us to get rid of that, the quickest, is by breathing that off. So the brain sends the appropriate message, and those come from the medulla oblongata, right? It's where the respiratory center of the brain is. And it sends that message to the diaphragm, hey, let's take some deeper breaths, right? Let's move that oxygen quicker so it increases your respiratory rate. And that's just what I talked about there. There's an inverse relationship between the volume of gas and its pressure, right? So when air moves in from areas of higher pressure to areas of lower pressure, air moves in from the environment into the lungs, right? And so here you have your diaphragm right here. This is the mechanical part of breathing. You have your diaphragm, your intercostal muscles that help to contract and pull the ribs up, right, to allow that diaphragm to, when it contracts, it allows those lungs to expand to receive air coming in. Then the diaphragm and intercostal muscles relax, which reduces the volume. Right, so if we're reducing volume, we're going to be increasing pressure. And what you're doing, guys, as we look at this, right? Here we're decreasing pressure, we're increasing volume, but we're trying to, at the end of the day, we're trying to create a vacuum. That vacuum allows, when you take a breath in, for that air to get down to the alveoli. So that's why we're even talking about pressure, to get it through to everybody that it's super important for alveolar ventilation to get the air down there. If it was bronchial ventilation, it wouldn't be as important. But when you already have so much dead air space, right, and you're only getting a few hundred milliliters of air to the alveoli, then it's super important that we get it there. So tidal volume, just to review, amount of air that moves in and out of the lungs. We're looking at around 500 milliliters for an average size adult. 150 milliliters remains in the airway and is unavailable for gas exchange. So that's dead air space, right? When we talk about expiration, stretch receptors and nervous signal stimulates the diaphragm and intercostal muscles to relax. And the higher intrapulmonary pressure in the environment allows for air flows out of the lungs. Remember, when you normally exhale, it usually doesn't require energy, right? So it's free. But if you are suffering from some type of respiratory disorder, well, now you're working hard not only to inspirate, but to expirate. And that's taking from your energy reserves. And we're already dealing with being more acidotic than we're normally used to. So yeah, it takes a toll on people. So respiratory problems can exist in various degrees. It can be anywhere from mild, moderate to severe. When they're highlighting mild dyspnea as short of breath. But then they're saying severe dyspnea, respiratory distress, barely able to speak, right? Those you're talking about, those 1 to 2 word sentences. Tripod position, you're going to have some audible wheezing, coughing, accessory muscle use. We can look here. They give examples of hypoxia and exhaustion. So this is when somebody who's in severe distress becomes exhausted. And I don't know if you've seen it or not, but when you have somebody tells you that they're too tired to breathe anymore, they mean it. And that's an imminent sign of respiratory failure. But we have cyanosis, altered mental status, their weak respiratory effort. And you normally use that example as knocking on respiratory failure's door. If they're not there, they're fixing to be there. Respiratory failure will lead to respiratory arrest if not corrected, ineffective respiratory effort, or apnea. Here in 20-1, you can look at this. It kind of goes through from normal respiratory distress, respiratory failure, and respiratory arrest. It's good information, it really is. You can look like normal breathing 12 to 20, but then they come over here to failure 8 or less or 30 or greater. Guys, really, honestly, it's all about chest rise and fall. If you have an inch of chest rise and fall, no matter the respiratory rate, your patient's more than likely not in failure. But we're going to use this respiratory rate to guide me. If I have somebody who's breathing 30 times per minute or greater, they're probably, if they're not in failure, they're probably going to be in failure. But that kind of allows me to look at that chest and go, okay, well, I have at least an inch of chest rise and fall right now. But I need to do something about this before we get to failure. Right. And so you can look at that. But at the end of the day, that's what it's about. An inch of chest rise and fall. All these other things are very good, like your patient's appearance, right? Respiratory distress, anxious. But then if we go over here to failure, we can look at, well, it says not only are they anxious, but they're probably cyanotic. Their level of responsiveness may begin to decrease, and the patient may be confused, right? I don't like to put everything in one box and go, well, if you have all of these symptoms, you are in failure, because it doesn't ever work like that in the field, and you know this probably by now. But what you're looking for is chest movement. But these are great because, if you have an exam, right, and they don't tell you, in the exam, they don't tell you you have an inch of chest rise and fall. They may say, hey, you have a 40-year-old male who's extremely anxious and with cyanosis to the lips, and their level of consciousness is alert-oriented times 1, and they're confused. You better pick failure, right? If they're not giving you anything to go on other than that, then I'm going to pick failure. But when we're talking about in the field and presentation, that's when I like to go and look at chest rise and fall. All right, maintain SpO2 of 95%. If a COPD COPD is present, your target becomes a little lower, doesn't it? We're looking now maybe 88 to 92%. And that's because these COPD patients, they're on that hypoxic drive, right? And so they're used to being somewhere between 88 to 92. That's a good day for them. But if I was 88% right now, I hope somebody's treating me, because that's not normal for me. All patients with inadequate ventilation require assistance by BVM with supplemental oxygen. Well, that makes sense. If they're not breathing adequately, meaning they have to at least have an inch of chest rise and fall, then if they don't, then yes, we will bag them. Maintain a patient's airway, breathing, oxygenation, and circulation are critical. Well, yeah, I mean, we learned that in EMT school. Good news or breaking news hasn't changed. Those are the three things you got to have. Attempt to reverse the underlying cause, right? And so we're looking maybe a diabetic. Maybe we have a diabetic patient who's in diabetic coma. The blood sugar's 20. And they are in failure from that. Because if you stay in failure long enough, sure, you can end up in failure if you're hypoglycemic long enough. So attempt to reverse that. So we'll start an IV. We will give the appropriate D10. That's our protocol here. It could be D50 somewhere else. Narcotic overdose. Attempt to reverse the underlying cause, provide the Narcan. So we're going to go through some of the assessments at this point. A general assessment, guys, for training, obviously, yeah, you always have to ensure your own safety, right? But you do that every day when you're in the field. You may not know you're doing it, but you're observing, you're looking for situations that may not be safe. But the next big deal that you really got to get good at, if you're not already good at it, is forming a general impression of your patient. And that's at 15 seconds. And 15 seconds is a long time to me. 15 seconds of not talking to somebody, of not listening to what they have to say, not doing anything. I'm taking 15 seconds and I'm looking at them. What does their skin look like? You know, are they gray? Are they mottled? Are they diaphoretic? Or do they look confused? What's their position? Are they tripoding or are they laying back? Do they look like they're in distress? You know, that general impression is everything because it tells you where to go. I can look at somebody for 15 seconds and I can look for at least 1 inch of chest rise or fall. If they don't have that, then I know, okay, this patient's in failure, and within 15 seconds, let's start bagging them. And I mentioned position, listening to the ease of speaking, right? Are they talking in 1-word sentences, or is this somebody who's talking 3 to 4-word sentences, or maybe they're talking in complete sentences? But either way, that's all part of your general impression. Your first 15 seconds there, you can pick up a lot of information. They're using here a bag valve mask, and yes, they're being assisted by someone. So hopefully, you know, you can control the airway without having to do this. But just in case, you have to be prepared. If you don't get chest rise and fall with your bag valve mask, it may require this. You want to always ensure your patient has an open airway. Don't forget about suction, right? And don't let it be in the ambulance or on the squad or on the engine or the truck, right? Don't let it be there when you need it. Try to get into a good habit of bringing that in with you. The one time you don't bring it is going to be the time you need it. So try to get in the habit too of checking it off in the mornings. If you're not looking at that, make sure the battery's working. Make sure it's good to go, right? Make sure that there's a yawker in it. Make sure there's O2 tubing. Make sure it works. All that's super important because when you need it, it's a bad day. You want to assess the adequacy of breathing. And of course, yeah, if you're going to need a BVM, let's use it with supplemental oxygen. If they have adequate ventilations, and what they should really hear or say is, if they have greater than 1 inch of chest rise or fall, then begin treatment with oxygen as needed. Sets a pulse, right? So let's say I have somebody who might be knocking on respiratory failure's door, right? They look bad. I mean, they have 1 inch of chest rise and fall. They're talking in 3-word sentences. They're tripoding, right? Let's take a pulse and look at it. If they're tachycardic, that's going to lead me, if they're tachy at 120, well, all right, so then again, I'm relating, how much time do I have before I'm going to have to intervene? right? How much time do I have before I put CPAP on? Or how much time do I have before I might need to start bagging this patient? It's something to think about. That's what you should always ask yourself when you're looking at these patients. Start asking yourself those questions. So respiratory distress can quickly lead to failure in those certain circumstances, right? So it's just something we need to be always aware of. And if you don't recognize failure quickly enough, it will lead to respiratory arrest. I like how they put in here, request paramedic assistance is needed. You don't need a paramedic's assistance to recognize your patient's in failure. You don't need a paramedic to come in and go, yeah, sure is. We need to bag this patient. No, you don't. You don't need a paramedic for this. You might need a paramedic for the other treatment involved in this case. That's why our patient's so sick. But no, you don't need a paramedic to tell you if this patient's in failure. That's up to you. So they want you to focus on the physical assessment details that are the most relevant, right? Auscultation of auscultation of lungs, right? Vital signs, pulse ox, capnography, cardiac monitoring, and medical history. But really think about this, because it's not just a slide that I'm throwing out there. Well, I know to listen to lung sounds, right? But what about when they mention vital signs? What are you thinking right now? Right. Well, let's talk about blood pressure, right? If I have somebody who's in moderate to severe respiratory distress, what can a blood pressure tell me? It tells me everything. If they're super hypertensive, then I just about bet the farm that they're congestive heart failure, pulmonary edema, sudden onset. Well, it's not really sudden onset, but they've probably been dealing with it for the past couple of days, but it's called flash pulmonary edema. And so, yeah, a blood pressure like that will tell me everything. And we run so many calls here in the cab where patients have histories of congestive heart failure and asthma. So if you treat these patients, if you treat a congestive heart failure patient like an asthma patient, well, you have a good chance of killing them. And so let's think about what we're doing out there. If they're super hypertensive, they're preloaded out, they're probably failure, treat them with CPAP. That's what they need. They need CPAP. Your asthmatic patient will more than likely, even with a history of hypertension, won't be super hypertensive. And we'll know then, hey, great, let's go ahead and start treating them with albuterol Atrovent. What does the pulse ox tell you? Because when I first started in this job, we didn't have pulse oxes. So they came out, I was like, great. It just confirms with something I already know, right? I put the pulse ox on somebody who's in severe distress, and I see 85%. I go, okay, I'm right. This patient is knocking on failure's door, and I better do something, right? And it gives me that. Or if they look really bad and they're 92%, I go, okay, and they're progressing to failure, right? But I still have a little bit of time, maybe. Capnography will tell you about are they retaining CO2, right? Are they blowing it off really fast? That's going to tell us a lot. Cardiac monitor, for a respiratory call, the last thing I care about, right? Yeah. I mean, I can look at the cardiac monitor rhythm and go, yeah, I mean, they're fast or whatever. But occasionally, this is not a cardiac issue. Even congestive heart failure, it's not an MI. It's not going to be something I treat with as a cardiac patient. Medical history, again, will be super important. If they have a history of congestive heart failure and asthma, then we need to be careful on how we treat them. So all of that's super important. These are just some medications that indicate a respiratory illness. I'll let you look through there. Of course, most of these you probably already know. If they're taking antibiotics, yeah, it could be suspect of maybe a pneumonia, maybe steroids, maybe a bronchitis or something like that. They're taking steroids for that. Anti-inflammatory drugs. can, like Singulair, they give a lot of asthma patients that. Bronchial dilators, asthma. So yeah, something to think about. And the list continues. Clinical reasoning process. Understand the patho of difficulty breathing, right? Does help us to know which questions to ask and develop and test hypotheses about underlying causes of respiratory emergencies. I just gave you one about being hypertensive, right? Those patients are normally failure patients all day. All right, so there you go. That's one hypothesis, if it's proven hypothesis. Nonetheless, clinical reasoning is what we're going to have to do when we're trying to come up with a way to treat this patient and coming up with the appropriate way. Maintain airway ventilation, oxygenation, and circulation. Well, that's the name of the game, isn't it? It sounds easy. It's not. It's not always easy. There's challenges on each of these. Intubation's always it's always out there as a choice. It's the best thing, like for a patient who needs their airway secured. But hopefully, maybe we treat them the correct way before we need to intubate them. You'll have the option in your toolbox of putting in a supraglottic airway. They don't have a gag reflex, right? If they're unconscious without a gag, yeah, absolutely, let's do that. CPAP's another big one, though. That saved a lot of lives over the years. Before CPAP, if you didn't have a paramedic there, you're probably going to die, and that's just pure fact. Because without CPAP, I have to treat these patients with drugs, or I have to put an ET tube down their nose, and that was the way we treated those. We don't have to do that anymore. IV fluids, right? IV fluids here are not going to save the day, folks. Matter of fact, they can make it much, much worse. Right? IV fluids is probably not something that we're going to use to get improvement on a respiratory type call. Nitroglycerin and epi, though. We have to think about these. Epi for your allergic reactions, and they're in super distress. Nitroglycerin, not so much in maybe some areas. Nitroglycerin is a potent vasodilator. If you have somebody with congestive heart failure, it's a great drug. I don't think it's in our scope for AEMTs to give it for that. But, if your patient, it looks like it's a cardiac patient and they're super hypertensive and they're in severe distress and they have chest pain, who's to say you couldn't use it? But anyway, I don't want to lead you down the wrong path. Here we go. We have this person here being applied with CPAP. They're talking him through it. It's super important to coach your patient. Coach them, let them know what they're going to expect, but coach them in a way of, hey, look, this is going to be uncomfortable for a couple of minutes, but we have you, okay? You need to try to tolerate this. This is going to make you a lot better, right? Talk to them in a good, calming, smooth, professional voice, and it will go a million miles. It will take, patients will trust you, but you have to talk to them in a reassuring voice. Talk to them like you know what you're talking about. Goes a long ways. All right, general assessment, management, reassessment. We're going to continuously, every 5 minutes on your serious patient, every 15 for your more stable patient. What are we looking for? Well, we have ongoing respiratory distress, which leads to acidosis. Hypoxia can lead to exhaustion, right? So that's why it's important to reassess, because occasionally you have a patient on CPAP, maybe if they lose their ability to maintain their airway and become unconscious, then we're going to have to start bagging them, right? Or you get your asthmatic patient, that becomes exhausted on you. It happens. That's why we had to continuously monitor those patients to make sure that we're providing the best care, because status changes. Status can change. And that's why it says respiratory distress can lead to respiratory to stress can lead to failure quickly. Check your mental status. So mental status is the first thing to change on your patient. If your patient, you start seeing that mental status start slipping, you need to start preparing to deal with a patient in failure. Be prepared to change treatment, right? You have an anaphylactic patient, you've given 0.3 milligrams of epi to, you're given albuterol atrovent to, they're still bad off, they're still hypotensive as all get out, they're still sat in the low 90s with the albuterol treatment on. Maybe it's time to consider a second dose of epi, right? Something to consider. You got to be prepared to change your treatment. Or maybe we have a patient that maybe it's an AEMT who didn't go through my class, who doesn't know how to recognize the difference between an asthmatic patient versus a patient in failure. And let's say their blood pressure is 180 over 110, they're tachycardic at 126, and for some reason we thought albuterol atrovent would be a good idea. And then the next thing you know, I call it the hypoxic fit. The patient starts slinging off the albuterol mask, starts telling you they're dying, trying to stand up as you're moving the stretcher, or as you're rolling the stretcher to the rescue. He's trying to climb off of it because he feels like he's drowning. Your treatment's not working at that point. It's time to start looking at something else, maybe CPAP at that point, right? So yeah, you've got to be prepared to change your treatment. Let's talk about COPD. Both emphysema and chronic bronchitis are considered COPD. This is the third leading cause of death in the United States of these Americas. All right. So they typically occur in middle-aged patients, and it's usually caused by cigarette smoking. But they say that all the time, but don't leave out these poor folks who have worked in factories their entire lives. And these factories were really rough on their lungs, and now they have COPD because of it. Some of them never smoked a day in their life, right? So something to think about. Difficulty in breathing caused by progressive destruction of lung tissue with decreased diameter, loss of elasticity, obstruction from inflammation and mucus production. All of this is happening where all of that's happening in the alveoli. Decreased surface area for gas exchange. So these folks have lost their ability to have gas exchange because their alveoli has been destroyed, right? These are the folks that can't walk to the mailbox without taking a break and dragging 4 miles of O2 tubing. The right ventricle works harder to circulate blood through the lungs, and due to the increased resistance to blood flow from damaged capillary beds, this results in the enlargement of the right ventricle, or called right-sided heart failure, and pulmonary hypertension. Because what happened was that right ventricle, since it was working harder, it went to the gym and it grew in size. Just like when you work out your biceps at the gym, when you work them out, they get big, right? Your right ventricle is no different. Digital clubbing. If you look at these folks' fingers, they'll look square sometimes, right? And hypoxic drive. These patients are on a hypoxic drive. They've lost their ability to be on the capnemic drive, and so their body's like, hey, our CO2 stays so high that we want to breathe 60 times per minute every second. So that's not going to work for our body anymore. So it switches over to a hypoxic drive. And if their O2 levels start dropping, that's when the body says, okay, let's breathe. Corpulmonal at the right side of the heart, failure that occurs because of increased resistance in the pulmonary vasculature. Right. And then we can look at some clubbing here. See how these figures are clubbed? They're like more square. Chronic bronchitis. This is, I thought maybe I was going to have to deal with this for like 3 years in a row, man. I had bronchitis so bad. And I was like, man, what is happening? Luckily, I haven't had it so bad in the last year or two. But yeah, chronic bronchitis, mucus producing cells in the bronchi, they increase in size. They produce more mucus than normal. And this usually results in somebody who persistently smokes. I didn't smoke, but I guess I went to a lot of fires. Maybe that's why. But anyway, don't let yourself get caught up, though, on just a smoker here. The patients, again, it could be somebody who just worked in a factory and got this stuff. Destruction of cilia allowed the bacteria to become trapped, and decompensation, acute exacerbation caused by that infection. All right, so what happens? Their cough, the cough produces sputum. They usually have wheezing due to bronchial constriction. These patients are usually called blue bloaters, right? They're larger patients normally, some of your larger, more obese patients. They just have this blue sign on it, look to them all the time, right? Prone to hypercapnia. This can lead to confusion, drowsiness, and headaches. Your emphysema patients. Remember, we talked about it. We talked about these emphysema patients. Their whole problem is their alveoli shot. It's gone. And they're paying a price for that. The body compensates by increasing red blood cells to carry oxygen. Doesn't work out too well because the alveoli is there and it needs to have gas exchange, and you can have all the hemoglobin in the world, but if you can't have a decent gas exchange, then you're just sick. We call these emphysema patients pink puffers. So just think of your bronchitis patients as your blue bloaters, but think of your COPD patients as your pink puffers. And the reason why is because of that increase in red blood cells. They have a lot of hemoglobin floating around, and that gives them that pink look. Respiratory distress, wheezing, thin with well-developed accessory. Yeah, they're always using accessory muscles, it seems like. They have air trapped in the alveoli. Because the alveoli is like swollen and enlarged, and air can get in, but it can't get out. And these patients a lot of times have barrel chest. So here's a normal alveolus. Here's a patient with emphysema. See, it's decreased surface area, right? For that oxygen exchange. See this mucus plugging up here? All part of the game. All part of emphysema or COPD. So what's the management of this? Well, we need to improve ventilations and oxygenation. CPAP or BVM is indicated. Got to be careful though with these. You got to be super careful with your COPD and your emphysema patients because you can blow along real easy. But if they need it, put it on them. We'll deal with the pneumothorax at the hospital. Supplemental oxygen, but we're trying to maintain on these patients around 88 to 93. You're not going to achieve. I say you're not going to. You can achieve 100%, but it's okay if we get 88. It's okay if we get 89. You know what I mean? These patients live hypoxic lives. Humidified oxygen, I'll tell you why. Don't worry about it for us. But these patients are on oxygen 24/7. The oxygen can dry their nose out. So they need it humidified inside the hospital or at the house. They can survive an hour ride with us or 30-minute ride with us without it. Sympathetic beta 2, right? So we need some beta 2. Let's dilate the bronchioles and do what we can for the alveoli that are left so that we can have a better gas exchange maybe. A sympathetic petroleum, this is Atrovent, right? That helps dry that mucus plugging up is what Atrovent does. See that? Atrovent will attack that, try to dry that up. IV fluids have indicated they won't be. Just INT's fine. Your asthmatic patients, right? So this is a big deal here in DeKalb County. We have a lot of people with asthma. We do lose patients in this county to asthmatic arrest. Chronic inflammation of bronchioles and bronchial constriction during an asthma attack. These can be triggered by a lot of different things. Stress is one type of asthma where stress can trigger an attack. Cigarette smoke, pet dandruff, your pollutants, exercise, infections, and other. All right, so bronchial constriction. Remember the smooth muscle and the bronchioles? Well, they're constricted. And it's that constriction plus this mucus accumulation that's a problem with this disease pattern. Signs and symptoms of a milder asthma attack. Well, non-productive cough, wheezing, chest tightness, shortness of breath, apnea, tachycardia, anxiety, and they got an O2 sat at 95%. All right, so all that's your signs of your more milder attack. Let's look at a severe. Severe is going to be got the signs and symptoms of what? A failure. That's what they're leading you down that road. Fatigue, exhaustion, the inability to speak. They're confused. Their mental status confused, or they're really drowsy. They're tired. They've been working really hard to breathe. They're cyanotic. Their breath sounds are diminished or absent. They would be diminished or absent because they're not getting enough chest rise or fall for you to hear the wheezing. Those are the worst ones. If they have absent lung sounds, it's because they're in failure, probably. Tachycardia or bradycardia. The patient becomes very tachycardic. If they start becoming bradycardic, they're on their way to dying. They're diaphoretic and they have a SAT of below 90. So how are we going to manage it? With bronchial dilators, right? With your albuterol, Atrovent. That's how we want to manage that. Right? So we want to establish an airway, right? So that might be making sure that they have one. Making sure they have at least an inch of chest rise or fall, right? And then it just kind of means from that point on, is this a CPAP patient, right? Might need to consider CPAP on this before we reach failure. You know, we can nebulize a treatment through the CPAP. Transport without delay, absolutely. Call for an ALS intercept. There's other drugs that we can give as a paramedic that help to turn these patients around. And I need to check. I know we can give epi. I looked at the scope of practice this morning. As a matter of fact, I didn't find it. I will consult to see if we can give epi for asthmatic patients, just like we do for anaphylaxis. But let me check. I'll have an answer for you soon. Make sure the patient's awake and breathing. We already kind of know what to do on this. All right, pulmonary embolism. Nothing we can do for the most part. Recognizing it is a great thing. If you have someone who meets all the risk factors of that, just being able to recognize it is a win. But let's look at the pulmonary embolism. The problem here, obstruction of the blood flow to the pulmonary artery, usually by a blood clot. Part of that lung is not able to have a gas exchange because the blood can't reach the alveoli at the capillary level to have one. Causes imbalance in ventilation and perfusion. We have a VQ mismatch. Hypoxia results, and the degree of that distress depends on the perfusion that's affected. Signs and symptoms: unexplained shortness of breath, tachypnea, tachycardia, hypotension, feeling of dread and anxiety. Yep. That's a big one. And the ones I've had, that was the sign that just telling you that they were going to die. Syncope, diaphoresis, chest pain. This would be pleuritic chest pain, not cardiac chest pain. Sometimes they'll have chest pain where they take a breath or they move. That's pleuritic chest pain. Coughing, hemotesis, and we know what that is. That's that coughing up of blood. Maybe a cardiac dysrhythmia. And sometimes with a clot, they'll have that swollen, tender lower calf. It may have been a few days ago when they had it too. It may not be sore anymore. Why? Because that clot's moved. So, again, substantial obstruction, experience sudden onset of severe respiratory distress, hypotension, severe hypoxia. These patients can and often do deteriorate quickly. And what they need is a surgeon and a thoracic surgeon. And if they're in that situation, you're seeing them in the field, chances are not good for them that they'll make it. A DVT, that's from that. It's what they were painting a picture of with this swollen tender calf right there of a DVT. Deep vein thrombosis. Patient has maybe you've had, these are the risk factors, by the way. Recent surgery. Maybe they've had cancer. They've been immobilized for a while. For females, maybe it's estrogen use. Recent pregnancy, right? Where they, and this could be like after delivery. Maybe they just got home with a new baby. They're at a high risk for a PE then. Or just an older age person. All these are risk factors that you should be aware of. Suspect pulmonary embolism with unexplained dyspnea and hypoxia. So any type of chest pain, and it's that pleuritic chest pain, syncope, hypotension, tachycardia, hemotesis, which I've never seen anybody coughing up blood then figured out it was a PE. But maybe it's out there. I don't know. Swelling of one leg, right? So they have unilateral edema, right? Something to look at. Cyanosis, cool and diaphoretic skin. Their mental status may be altered, or they're sliding into respiratory failure. A diesel drip here would be the pre-hospital treatment. Obviously, treat them with oxygen, even though they're not getting it to the right place. Pulmonary edema is a different story. This is something that we often see it here in DeKalb. Occurs with an increase in interstitial fluid, increased distance of gas diffusion between the alveoli and pulmonary capillaries. Because what happens is their blood pressure is so high, they're hypertensive, that those capillary pushes away. They push a little further up, and it's hard for that diffusion to happen because of that. Like this right here, here's your capillary, here's your alveolus. You see that? Sometimes it'll actually, let me get a pen real quick. Sometimes it'll actually, well, that's not really what I wanted to do. But you get my drift. It'll actually push away, and it'll cause a problem with the distance. Yes, it will. Let me erase that. So this is left-sided heart failure. And yeah, nitro is great for this. It definitely helps. I will get some answers about that. I don't think we can treat pulmonary edema. It's inside our scope of practice with nitro. but it's a good idea. All right, pathophysiology continues here. So what we show here is the actual pulmonary edema. Here's the capillary again. Fluid comes in between the alveolus and the capillary, pushes the capillary away, and it makes gas exchange extremely difficult. This is a non-cardiogenic pulmonary edema. Can be caused by acute respiratory distress syndrome. Can be caused by toxic substances that reach the lungs that can lead to non-cardiogenic pulmonary edema, like chlorine. Like if you maybe sucked in some chlorine from the pool house, that could cause your lungs to kind of to have edema, and that could cause a pulmonary edema. Spontaneous pneumothoraxes, these are non-traumatic pneumothoraxes that happen. A lot of times people have something called a bleb or a blebby in their lung. It's a weak piece of their lung, and it just happens to leak out air. These take time to develop, but once they start developing, it can turn into a simple pneumothorax. Here we go. Here's a picture of that bleb right there. And the lung can actually begin to collapse. So, we're going to provide some oxygen therapy for this. BVM if necessary. Hopefully it won't be. Hopefully a non-rebreather will fix it. At least maintain it until you can get to a hospital. Reassess patient frequently, monitoring mental status. Yep. That's why it's spontaneous. Sometimes it's hard to pick up because you think a lot of times with pneumothorax, you're thinking trauma, but not always the case. It can actually be a medical call. Tension pneumothorax, this is where a spontaneous leads to a tension, right? So a defect in the lung, large, cannot seal itself. Air continues to accumulate. It cannot escape. It begins to compress the mediastinum and collapses the opposite lung. So this is a critical life-threatening emergency, right? So it's something we got to worry about. Severe distress can lead to respiratory failure. It's actually, can lead to, it can lead to profound shock. If that lung collapses and it lands over the heart, it can reduce cardiac output, and that can lead to some serious shock. You'll sometimes have distended neck veins. Again, hypotension, and what I just mentioned. Tracheal deviation is a late sign. So if you ever see the trachea deviated, it's going to move to the opposite side. So if the trachea is deviated to the left, it's because the right lung has a pneumothorax. A needle thoracotomy, or needle decompression to the chest is an ALS procedure. A paramedic can do that. You can request ALS and meet them somewhere in between if you suspect it. We'll definitely probably have extremely diminished, if not altogether absent, lung sounds to that affected side. We don't want to hyperventilate this patient, right? No, because the more air we put in the chest, the worse the problem gets. Right? You can start an INT, an IV. Your patient sometimes will be hypotensive, so you can hang a bag, a normal saline, and infuse it. That's fine for the hypotension. And notify that receiving facility, give a good report so they can have the appropriate equipment, like a chest tube and all that, in the room for you when you arrive. Again, these are some signs that tells you out the differences between simple versus tension pneumothorax. I'd just be aware of that. I would go through that. Hyperventilation syndrome. Again, these are usually psychiatric type things or something like that causes a hyperventilation syndrome. I think y'all are familiar with that. I don't think there's a lot of reason to go into that. infectious respiratory diseases, right? Anything from viruses to fungi to bacteria, they can cause an infection to the upper or lower respiratory system, right? Like tracheitis, right? Inflammation or infection of the trachea. So upper respiratory diseases are rarely life-threatening. And so like a lower respiratory infection, maybe a pneumonia is an example of that. As a matter of fact, here we go. It's community acquired or hospital acquired. If you have a very weak immune system, it can be fatal. These patients, when they have pneumonias, they typically have fevers, chills. They don't look well. They look very look like they're sick, right? So they will benefit from a bronchial dilator like albuterol, Atrovent, IV if they're dehydrated from the fever, right? It's probably a good idea. If we're dealing with them, they're probably septic due to pneumonia. This slide explains some of the differences between pulmonary edema versus pneumonia. You can look through there. I would tell you that your pulmonary edema patients are usually going to be in more respiratory distress than pneumonia patients are. Your pulmonary edema patients are probably going to be hypertensive, or they are going to be hypertensive, when your pneumonia patients will not be. You can look in your pulmonary edema patients. A lot of these patients have upper and lower extremity edema, versus pneumonia, not so much. Again, more of that. Infection, here we're talking about acute bronchitis, right? A lot of times viruses, bacteria, irritants. These are usually not bacteria. A lot of times these bronchitises are more viral. A lot of these patients have wheezing, cough. They don't, like your pneumonia patients, if they want to do me like this, that's fine. They can do me like this. I don't care. You want to say both have fevers, that's fine. Your pneumonia patients are going to have your super high fevers. Your bronchitis patients, probably low grade, if fever at all. They also benefit from your albuterol, Atrovent as well. They will benefit from some supplemental oxygen. And if they're, again, sick enough to where they have a fever, they could benefit from some fluid. When we talk about SARS and HPS, your influenza patients, these patients usually have more than just respiratory involvement. Their body aches, fever, muscle joint pain, and cough. Lung cancer patients, a lot of the times these patients are, they're lung cancer patients. A lot of them are dying. These patients, we are concerned about having a pulse or a DNR. Not a lot there. Cystic fibrosis patients, it's a very rare genetic disorder. This is where the patient's secretions in their lungs, instead of it being a benefit to having like some mucus in the lungs to help the air get down to the alveoli, well, they have too much. They produce way too much secretions, and these secretions become thick and infectious. They benefit also from your albuterol, Atrovent, bronchial dilators as well. All right, so what we talked about in this chapter is acute and chronic respiratory problems. We talked about respiratory distress, how important it is to understand the differences between someone who is in mild to moderate distress versus someone who is in respiratory failure. We talked about problems like disease patterns that affect respiratory, such as COPD. We talked a little bit about lung cancer. We talked about asthma. We talked about pulmonary edema. We talked a little bit about hyperventilation syndrome, but not much. We talked about infectious disease and cystic fibrosis. We talked about how quick you got to be in recognizing that what type of distress the patient is in and being quick to treat it. All right. That is it for the respiratory chapter. Be getting the cardiac chapter out really soon. The next, let's see. We have, that and neuro to cover. All right. Have a great day. Look forward to talking to all of y'all soon.